Good afternoon, everyone. You're all very welcome to our Aware webinar today on menopause and mental health. My name is Dr. Susan Brannick, and I'm joined today by Dr. Caoimhe Hartley, who I'll introduce more formally in just a moment. A lot of people registered for our webinar today, so I'm just going to give a few moments or so just to let people join. So settle in and we'll get going in just a minute. So welcome again to those just joining. My name is Dr. Susan Brannick. As I said, I am a clinical psychologist and clinical director here at Aware, and delighted to be joined by Dr. Caoimhe Hartley, GP and Menopause Specialist, to talk about our topic today, menopause and mental health. So just before we get into our discussion, just a bit of information really about our webinars. So for those of you who might be new today, we do these webinars on the second Wednesday of every month about a range of topics on mental health. So do have a look at our website for more information on those. And certainly, I guess if you're joining today, maybe experiencing anxiety or depression specifically, have a look at our webinar a few months ago back on anxiety. That might be of use, as well as the rest of the videos that are there. So what we'll aim to do, I suppose, is have as much time as possible for questions, but unfortunately we can't answer any specific individual kind of medical queries. So we can't give medical advice, which we'll speak a bit to more as we go on. But do pop your questions in the chat as we go. We'll have time throughout maybe to address more general issues that come up that Caoimhe might be able to talk to specifically around menopause and treatment. But do talk to your GP if you're left with any queries after our session today. So maybe without further ado, Caoimhe, yeah, you're very welcome again. Just to introduce you again, as I said, GP and Menopause Specialist, and delighted to have you on today. You had joined us, was it 3 years ago? To talk about the menopause, and it's really interesting. I think in that time, so much more attention has kind of been given to this area. Even we see in the registration for the webinar today a huge amount of interest in this topic.
There is indeed, yeah. I mean, I'd like to start by thanking yourself, Susan, and Siobhan, and everybody at the team at Aware for doing this, because this is part of how it does get into the zeitgeist and people talk about it and people learn more about it. It is important that we're talking about all different aspects of healthcare, and menopause is no different. But yeah, it was a different landscape, I think, when we spoke back in 2021. And I did the webinar last time. I had actually only just set up my clinic. I was sitting at some garden furniture. I didn't even have proper furniture at that point. And it was really the start of things. I had been working in women's health for the guts of sort of 10 years before that. So it wasn't new to some of us. I guess we knew that there was a kind of shift and things had changed, and the way we looked at things like perimenopause, the impact it had on women, menopause as well. And then the way we looked at HRT, for example, probably had changed a few years before that. It was just taking time to trickle into general practice and trickle into what we were actually seeing patients talk about. So it was a very welcome change. And then in the last few years, I guess even things like the free HRT scheme, which we're hoping will come into effect now in January, the complex care clinic. So I work a couple of days a week in my own practice here in Dalkey, and then I do a couple of days a week running. I'm the clinical lead for the complex menopause clinic that's run through the Rotunda Hospital. And we would see women who have maybe more complex medical problems and are trickier to maybe navigate with general practice, and they would come in and see us in the hospital. But they were established off the back of the change in attitude, I think, to not just menopause, but women's health in general in the last couple of years. And I hope women have really benefited from all of that and from that change.
Yeah, it sounds like there's been a huge amount of movement, hasn't there? Yeah. And the complex menopause clinics, are they all over the country, or is that just in Dublin, or?
No, there's 6 of them. So we've 2 in Dublin. Myself and Deirdre Lundy would be counterparts. So Deirdre runs the clinic with Nicola Cochran, who's another fabulous GP specialist, and they're based out of Holles Street. I'm the Rotunda, and then we have a clinic in a fabulous clinic in Galway, another in Limerick, and then one in Cork as well.
Oh, okay, great.
That's 5. Oh God, I'm missing one. Who am I missing?
Well, don't worry. We can put it in the information after.
It'll come to me. Yeah, but anyway, so we've 6 altogether, and
yeah, great.
so yeah, they're great. They're great clinics. Yeah.
Yeah, and just as you mentioned, it's of interest maybe, and we'll kind of maybe come into that in a bit more detail. But if someone was to get referred into that, how do they, or what's the pathway?
It's primarily through your GP. So
Okay.
when you attend the GP, they can do it through an electronic system called HealthLink. They can refer directly to ourselves or to the National Maternity Hospital, and it depends on your, like, there's catchment areas, so it depends on where
Yeah.
you're living.
Okay.
But if you feel you might qualify, your GP would know the different criteria that we have. It's worth a discussion with
Mm.
your GP, and they can do that
Okay.
for you.
That's really helpful. And I guess it might be one of the first of many times we come back to that idea that it's probably first port of call is going to be the GP.
It's your
If
GP,
you're
yeah,
kind of tuning in today and thinking, oh, I wonder what the next step might be for me, most likely GP.
yeah,
Um,
yeah. I'd
Brilliant.
agree. Yeah,
Yeah.
yeah.
So, and I know, and it might be familiar to like some of the audience and maybe not to others, but I guess maybe just getting into kind of definitions first, just kind of so we're all on the same page about what is the menopause, what's perimenopause, that kind of thing.
Yeah, I mean, no harm sort of setting the scene and starting with
Yeah.
the basics, but because it trips people up, and I think one of the issues is that there's a lot of medical terminology in all of this, and
Yeah.
that can be really confusing. So menopause itself is just the medical term for your final period. That's all it is. So just like we have your first ever period, that's called menarche. That's the start of. It's not actually the start of puberty. It's almost the end of your kind of pubertal change, but equally, so we've menarche at the beginning, and then that's bookended on the other side of your reproductive life with menopause, which is your final period. And on average in Ireland, that final period happens somewhere around the age of 50, 51. And we know if you go 12 months with no bleeding for no other reason, pregnancy and
Sure.
medication and all the rest. So if you go 12 months with no bleeding, we're really confident your ovaries have stopped functioning at that point. And we're also really confident statistically that you will not have another period and you won't go back to having ovulation or ovarian function. So the 12-month is kind of arbitrary, plucked out of the air a little, except it's kind of to help from a medical perspective decide who should be investigated and who shouldn't if they have further bleeding. If you get a bleed after 12 months, that needs to be investigated by definition. So once you've gone a year, we're really confident that's it, that's you. Ovaries are kind of, not ovulating, you're not functioning much anymore, probably not producing a huge amount of estrogen or progestin anymore. And from that point on, you're postmenopausal for the rest of your life. So that's menopause and postmenopause.
Yeah.
Perimenopause, a bit trickier, a bit slipperier. It's hard to kind of pin perimenopause down. But if you think during most of your reproductive life, you have estrogen production that's kind of up and down from your ovaries in a nice cyclical pattern. Most women ovulate on average, most like once a month, so maybe 11 or 12 times per year. And then when they get to somewhere around their mid 40s, on average, but there's huge variation. But just if we go with average, somewhere around the age of 44, 45, that ovarian function starts to change. And instead of this nice, smooth up and down pattern, it starts to become a bit more chaotic. And we see a lot more variability in the amount of estrogen produced from month to month, sometimes too much, sometimes too little. And it's a lot more variable from month to month. That creates an awful lot of the symptoms that we associate with perimenopause. And it's really representing or reflecting your ovaries starting to struggle a little to kind of keep going until you hit your final period, whenever that happens. And on average, it's about 5 years. But like, again, obviously a lot of individuality within that. And then
So there's probably
symptoms
going to
happen
be,
all around that.
yeah, yeah. Um, and I guess there's quite, we'll maybe talk about it as we go through quite a lot of symptoms. And I suppose this is on mental health, but also it's probably helpful to kind of have the kind of broader picture generally of the whole body, isn't it? And what's sort of happening across the board because
Yeah,
of course, they interact.
they do. And I think it's helpful. Like, you'd read a lot of things by people kind of comparing perimenopause and menopause to puberty, which is a kind
Mm,
of unfair comparison because they're two very different things. But what they have in common, if you think of puberty, like I'm sure we were all in school with girls who had mood issues related to kind of puberty and their periods, and other girls who had really heavy and painful periods, and other girls who seemed to have no issue whatsoever, or acne, or obviously a whole spectrum of different symptoms in puberty. And perimenopause is the same. So when those hormones start to fluctuate, there's a lot of individuality as to how your brain responds to those fluctuations and how your body responds. A lot of that is actually genetics. Like, we're built differently to each other. But you have estrogen receptors fairly kind of from head to toe pretty much, and that's why you can kind of get this myriad of symptoms from head to toe. It's helpful maybe to split them into more mood and emotional, the kind of brain related symptoms, if you like, versus more physical symptoms like hot flushes and night sweats. And then we have what we call genitourinary symptoms of menopause. Doesn't really roll off the tongue. It used to be called vaginal atrophy, which is an even worse term.
Yeah.
But anyway, so we kind of split it into those three categories. What I think is really interesting, and one of the things that has really changed in the last few years with regards to attitude to all of this, is acknowledging that actually the literature supports the fact that most women are at their most symptomatic. They feel their worst when they're still having periods and they are perimenopausal, before their final period has actually happened. Traditionally, we would have dismissed those women, but you're still having periods. You're too young, like move on, and you come back to me when your periods have stopped. But we've actually missed a window where a lot of women find themselves to be very symptomatic. And I think it's really important to point out that there is at least a fifth of women who aren't symptomatic and who do fly through menopause and are fine and go through that menopausal transition, all those hormones changing. Their brain is trying to adapt to this hormonal change, a new hormonal environment. And for a fifth of women or thereabouts, it doesn't bother them. They don't get particularly impactful symptoms. I mean, great. But I think it's important, just because otherwise we don't want we don't want everybody in their 30s to think, oh my God, what is coming down the line? Terrified. It's not all bad news. Lots of women are fine. What we do want is to reach the women who are having really impactful symptoms in perimenopause or after their periods have stopped, and for them to know what is a hormonal symptom and what can I do about it and who can I talk to about it.
Yeah. It's really important, isn't it? I guess you didn't, I'm thinking about, you didn't really hear about perimenopause, did you? Like about 10, 15 years ago, as you say, maybe it was kind of people weren't kind of being picked up in that phase. And did you say the age ranges for that?
So there's a wide age range, just as there
Yeah.
is for menopause. So about 1% of women will stop having periods completely under 40.
Okay.
Genetic factors, other things can contribute to that. And about 5% of women under 45 will stop having periods completely. A small percentage, but not
Yeah.
tiny. So if we kind of then, if you stretch that out to say, well, how many women under 45 have had hormonal change and are perimenopausal, it's actually quite a significant, well, maybe that's an exaggeration, but it's not a small percentage.
Okay.
So the range is really from, like, on average from 40 onwards is when we start paying attention. But it can technically happen at any age. I mean, I would see women in my clinic who are in their late teens, early 20s who have stopped having periods. So, I think I wouldn't impose an age range on it. I think if you're symptomatic, you talk to someone and we just take it into account, and the woman who comes in who's 25 with regular periods, we're just less inclined to attribute things to perimenopause for obvious reasons there. But you're a bit like a detective combing through someone's symptoms and combing through their history and maybe their menstrual pattern and different things to find clues to see what might be a hormonal symptom and what might not. But it's very difficult, and it can be difficult. When you're younger, I think it's much easier to be ignored and dismissed. So that's a challenge too.
Yeah, and I guess, as you say, a bit of a detective, and maybe people themselves can support that through kind of keeping note of stuff. Some people are very good at that, other people not so good at kind of recording maybe when mood might change, what sort of how the kind of cycle is going. So that can be maybe helpful in terms of the self-care in this phase. But it's an interesting idea, isn't it? Because you might be a certain age, like 39, 40, and think, well, that doesn't apply to me. And it may not. But also it's possible that it might be relevant. So I guess it's, as you said, not being quite so strict on the age range. It sounds like it's quite individual.
Extremely so, yeah.
Yeah. Okay. And I guess, how would you, in terms of thinking about how you would know if someone was perimenopausal or menopausal?
So this crops up all the time. I think there's two challenges here. One is to try and establish, are your hormones fluctuating more than they used to in the background? And the problem is, because you're trying to measure something that is by definition moving around and fluctuating, it's impossible. So a lot of women will come in saying, look, if you've stopped having periods, that's kind of cut and dry. I know what your ovaries are doing. They've told me you stopped having periods. That's great. If you're still having periods and they're irregular, so you used to have a 28-day cycle and now it's either 7 days shorter on average or 7 days longer on average. So a difference of about 7 days either way. That's a good indication. That's a sort of obvious reflection that something has changed in the background. That makes life really easy. However, if you come in with relatively regular periods, but symptoms, I'm not feeling great, my mood is different. The week before my period, I feel dreadful, I have a lot of anxiety or rage, I have the odd hot flush. Like, it's all, you're getting these symptoms and we have regular periods. It's much more difficult, obviously, to establish what's happening in the background. So if you're still having periods, there's no point doing bloods, because what are they going to tell me? If I measure an FSH level, which is the hormone that your brain produces, kind of the puppeteer controlling your ovaries, it's going up and down in response to what your estrogen production is doing. If I try to measure estrogen, it is all over the place. And so none of that helps. So we don't find measuring hormone levels in women who are still having periods in any way helpful. If you're over 45 and your periods have stopped, again, we don't really need to measure bloods there. If you're under 45 and your periods have stopped completely, because that's less common, we want to make sure your periods have stopped because of menopause and not due to something else. And so it can be helpful to measure blood work there. And we would sometimes in the clinic here, we would do, you look under every stone. And the problem with something like perimenopause and menopause is the fact that there's mimickers out there. It's really, somebody could come in with really bad fatigue. And like, I obviously think everything is hormonal, everything is menopause if you work in here, but it's not in reality, obviously. So we're really conscious of that bias. So it's important you have your thyroid checked, and we do a blood count looking for anemia, and you go looking for other things, because the last thing we want to do is to go barking up one tree and miss something else really obvious. So it is like, bloods have a role, but not necessarily hormone bloods. They're not helpful for most women, for the most part. Yeah.
Great.
It
And
comes down to your symptoms, really, Susan, at the end of the day. It comes down to the clinical picture,
Yeah. No, that's really helpful, isn't it? So there's not going to be a specific marker, as you said, that fluctuates anyway, but it's more about symptoms and probably impact as well. And I guess
definitely, yeah. I
as
think
you
what's
said,
really interesting, a lot of women will say, I'm getting hot flushes or night sweats. And I kind of jot that down and think, okay, hot flushes, and I have to treat the hot flushes. And they go on to then say, but my brain isn't functioning, or I have really bad anxiety and I can never think of the right word, and my confidence is really low. And I'm off thinking that the important symptom that we should be treating is hot flushes, but they're thinking, never mind your hot flushes, they're manageable, I can live with them. I can't remember anything and my mood is awful. Like, so that's where the impact comes in. And I think that's why, from a general practice point of view, you're given 15 minutes, if you're lucky, sometimes 10 to see a patient. GPs are brilliant and they are well able to do this. We have 45 minutes to try and help you untangle all of your symptoms and figure out what's the most impactful, what should we be treating, and kind of what's causing what, if we can.
Yeah. No, that's really helpful, I think. And I guess the word that popped up, it might resonate with people watching, it maybe irritability and rage you mentioned earlier, and maybe helpful to think through into those kind of that category of symptoms, the kind of mood and emotional kind of mental health piece around this. What do you see?
Yeah. I mean, estrogen is a regulator. We know lots of things regulate serotonin production in our brain. But one of those regulators is estrogen. So we know, like, there's an explanation for why we see things like reproductive mental health. So you might see new depression and anxiety at the time of puberty, through pregnancy, postnatally, and then at menopause as well. So any kind of big hormonal change or transition can trigger changes in mental health. And as you well know, like, it changes from person to person. For some people, it can be pervasive low mood. For other people, it's more on an anxiety spectrum. For some people, it's both, and it's a mixture of the two. And so it really kind of covers across that kind of mental health spectrum. But, we also know progesterone, so the hormone that you produce when you ovulate, is really neurologically impactful. So it's actually a hormone that you make in your brain, which is really unusual. You don't make any other reproductive hormone from cells in your brain, but you do actually manufacture a tiny bit of progesterone. And we know it has an impact on things like anxiety, for example. So it can reduce our own progesterone can reduce anxiety. It can improve sleep. It's one of the reasons people often feel really well in pregnancy, is because they have an abundance of these two hormones and they're really stable. They're not fluctuating at all. And if you look at HRT, a lot of women who start uterogestin, which is body identical or micronized progesterone, it's kind of mimicking what your ovaries produce when they make progesterone. We know that has a weak anxiolytic, like anxiety reducing effect, and a weak sedative effect. So it's really neurologically impactful. So these hormones are every bit as important for our mental health as they are for every other part of us. But how they affect you will come down to things like your history. Women with a pre-existing history of low mood or depression or anxiety are probably a bit more vulnerable to having those symptoms occur at the time of the menopausal transition. And women with a history of postnatal depression, same idea. And genetics, we know that genetics have a huge role to play here as well. And your environment to some degree as well, like the other stresses that are on you, the amount of support that you have in life. It's a big melting pot of all of the above. But yeah, mental health is a hugely important piece of what we see happen at the menopausal transition. Absolutely.
Yeah. And I guess a lot of the questions are coming in, and I guess the interest in this webinar, I suppose, is predominantly kind of around that piece. And I guess we've spoken before, hadn't we? And that idea of kind of a lot of women might feel very alone in this, the kind of that maybe, as you say, there's kind of possible. I'm not sure if you'd agree. There's maybe two different types of cohort, maybe. So maybe people who haven't had a lot of difficulties with mental health, and then they hit kind of perimenopause or menopause and things really change. So really being hit by really kind of out of character experiences of agitation, anxiety, maybe panic attacks, or maybe mood kind of really, really getting very low. And then, as you mentioned, kind of maybe people who have had a history of mental health challenges that might enter the menopause from that perspective. They might be a bit different, do you think?
I think you're right. I think there are those two cohorts. Yeah. And I always think it's sort of fascinating, women who've never really had an issue previously. Anxiety is actually a really big one with this because
Yeah.
it really hits them full force like a truck, and they get to usually perimenopause, and it's triggered by the more extreme hormonal fluctuations, and they're absolutely like just like completely hit in the face by it. And a lot of women describe things like driving. See, it seems to be, I don't know why, but seems to be a very common trigger for a lot of women. Will say, I used to be able to drive in the M50 or drive from A to B, and now I can't, and I don't know why I can't, but I can't. I had a woman memorably a couple of years ago who gave up work as a consequence because there was so much driving in her job, and it was just actually, it was crippling her anxiety, but it never happened to her before. And that in turn then has a huge impact on confidence too, and it's all kind of wrapped up, and you can get really into the meat of this and say, well, like, there's also our attitude to aging as a society. And so I think what's interesting about menopause is that it's this combination of, there's societal elements and cultural elements and how we view aging and how we view ourselves with all of that. The loss of reproduction can be actually, like, it's akin to grief for a lot of women to realize they're now at kind of that part of their life where they may not have spontaneous reproduction, and that can be very difficult, letting that go. And so there's a whole kind of psychological aspect to it, and then there's biology. And we know there are very real, demonstrable, like, you can put women in a PET scanner, image their brain, and see changes that add up or relate to the changes that are happening in their blood or serum estradiol, estrogen levels. So you can actually show women, your brain is, it's not, you're not going mad, and what you're feeling is not your fault. It's not that you've somehow become less confident, or you've less kind of motivation because you've less get up and go and your personality has changed. It's properly biology that has changed in the background. The reassuring thing is that we know, and not for everyone, but for the majority of women, that if we don't intervene, that with time, a lot of these symptoms will actually resolve. The cognitive changes, the low mood, the anxiety, for a lot of women improve with time. It's not all bad news, and it doesn't mean everyone has to treat it, and you don't have to go on HRT. And a lot of women, just naturally, their brain gradually adapts and adjusts to not having estrogen. And when you get to menopause and your periods have stopped, a lot of that fluctuation has just become more stable anyway, and that's helpful. But I think pinning it down to biology is important, and saying,
Yeah.
we can measure this. There is biological changes happening here. We can intervene if necessary. We have loads of different options for managing these symptoms. But yeah, and I think women who have a history of issues with low mood or depression or anxiety in the past can be very anxious coming into menopause, wondering what is going to be thrown at me. And we don't know any more than you do, which is the problem. I don't know what's coming down the road for anybody a lot of the time. So sometimes there are women who benefit from having an early conversation to kind of get that scaffolding in place around you. What am I going to do if something happens and my mood worsens?
Yeah, I think that's really important, isn't it? Because I guess even as we started off this webinar saying things have really changed, I don't like we just wouldn't have been having this conversation even in Aware like in 1987, you know, like not long after we had started. So it's there's something in there too about, and as you say, it sounds like it's really different for different people, and you know, a lot of these changes for people might be very intense, but also might resolve over time without intervention. So it's going to be quite unique, but maybe there's something about being kind of prepared if you have had challenges in the past. And maybe if you know, if your cycle has been kind of challenging as well, maybe both of those areas, thinking about how am I going to navigate this next phase, could be useful. I think there's something too about the biology piece, isn't there? And as you said, that it's not that you're going mad. It's not that like these are, you can see these actual changes that are affecting mood. And I think there's maybe a really key piece about there's different psychological kind of approaches in that too, isn't there? We know CBT can be really helpful for anxiety and depression kind of generally. I think there's a specific CBT protocol actually for menopause, but also self-compassion. So kind of not being self-critical or hard on yourself if, you know, maybe times of those irritability, or if something feels very disproportionate that you know you wouldn't usually react in that way, but it seems maybe to take on a higher kind of meaning. I don't know
Well,
what you
if you
think.
think of a teenager, not, and I'm not saying it is not the same, it's
Yeah.
not. But a teenage and adolescent brain is having to also adjust to a new hormonal environment. And we know that that is some of the issue with like temper, like losing your temper, poor judgment, impulsive behavior, different things like that can, you know, that's biology too, except
Yeah.
from a society point of view, we give a lot of slack to teenagers, I think. Like they're given a little bit of room to allow to kind of weather that hormonal storm until they settle down when they're a bit older. You hit perimenopause, there's no room. You're given no room. You are a grown ass woman, put your big girl pants on, you know, keep your stuff together. And I think a lot of women feel, especially, you know, if they don't have a lot of support at home, or they don't have a supportive partner, or they don't get support in work, I think that's one of the issues, is that there's this expectation that you are unchanged. There's no leeway at all, but you're battling this kind of stormy sea in the background, and this biology in the background. And it just adds to the anxiety of the whole situation, and really compounds the issue. But I think it's our attitude towards it. And I think, like you said, that self-compassion of saying this isn't your personality that has changed. It's biology. You're strapped into a hormonal roller coaster. It doesn't mean that we don't do anything about it, but you can't blame yourself for it. And I think, you know, reaching out and talking to the right people and looking for help if it's really impacting you is really important.
Yeah, I think that's really key, isn't it? And I guess it just makes me think, as you say, so kind of that idea that you should have everything together, but also you're probably at that stage in life holding down probably quite a senior job, maybe kids, maybe not kids, maybe elderly parents. So there's a lot of different
A lot of
competing
plates that are
needs, maybe.
spinning here in the background. I know,
Yeah,
yeah. And then the constant guilt of like, well, I'm not, you know, you're not doing everything right
yeah,
or everything perfectly. And so that just gets thrown, like there's an awful lot piling on top of you, I think, at this time of life.
yeah,
And
yeah,
then throwing a big kind of hormonal transition into the mix just isn't helpful for anyone.
yeah, yeah, yeah. A big
You know,
hormonal mix that no one ever really talks about or acknowledges is happening. So yeah, or maybe we're getting better in that. So it's
and you had talked about loneliness, and I think, you know, or that feeling of isolation often going through this time of your life. And I think some of that maybe stems from the fact, like I obviously sitting here and I see nothing but perimenopausal and menopausal women all day long, and they're all completely different to each other. And I'm sure people relate to that kind of sense of like you could chat to your neighbor or sister or whoever who has had nothing but physical symptoms, and she's
yeah,
telling you, oh my God, aren't the hot flushes in nights? That's awful. And you're thinking, I have no idea because I'm not getting them. But like, I wake up in the morning with a rock of anxiety in my stomach when I wake up in the morning, and I'm not sleeping. And then your neighbor up the road, totally different set of symptoms. It's hard to find common ground. That can make it very lonely and isolating too, which is a
yeah.
challenge, you know.
Yeah. And I guess this, yeah, kind of maybe linking in, as you say, kind of maybe our GP, but also kind of linking in with maybe other people who are having similar experiences can be helpful. I guess that we'll maybe talk a little bit. There's loads of questions coming through, and I suppose we haven't specifically kind of mentioned HRT yet or testosterone, but I wonder, is it worth saying a bit about, so you talked to your GP and now the next step, what's gonna
How long have you got, Susan?
Yeah.
So yeah, I mean, the way that we approach most things, it actually, whether someone is perimenopausal or has finished having periods and is menopausal, doesn't matter from a treatment perspective. So I'd kind of advise women to not get too bogged down into kind of, where am I on this timeline? Because
Yeah.
the timeline itself is a bit fluid anyway, and also it doesn't matter.
Yeah.
Realistically, in terms of how we manage things. So we would start with everyone, we look at lifestyle. Like, we start with a holistic approach as much as we can, and we talk about exercise. Even from a mental health perspective, we know the benefits of exercise. We look at sleep. Like, sleep seems to underpin an awful lot of what throws people off during the menopausal transition. And again, sleep, like everything else, is multifactorial, and it can be mood and anxiety related, or you're awake because of your night sweats, or it's actually just changes in things like melatonin production and that kind of thing throughout menopause, like a real kind of biological effect, or you have a partner who snores, or all of the above, or God knows, it depends on the person. So that's a whole conversation in itself. And for a lot of women, if we get their sleep right, everything else falls into place for some women. So we look at lifestyle, we look at sleep hygiene, we look at things like counselling and cognitive behavioural therapy. The new NICE guidelines from the UK that haven't been kind of completely finalised and published yet, but they're heavy on the CBT.
Yeah.
They were kind of criticised actually for almost being kind of too biased towards using cognitive behavioural therapy above all else, which was, controversial. But I think it maybe reflects the fact that we do have good evidence that CBT and counselling are helpful at this time in your life and can make you feel better. And not for everyone, but for a lot of women, they can benefit from that. So we talk about that. And we talk about diet. It's a really good time. It's opportunistic at this time in your life to look at long-term health. So we use it as a kind of also an opportunity to really maximize and optimize the next 50 years of your life, the other half of your life that you're going to be on the other side of this transition. So we look at two areas in particular. One is bone health. So things like vitamin D is important. Most women in Ireland will need some vitamin D supplementation through winter in particular, and that's often just over the counter in the pharmacy. Plenty of calcium in your diet, 1,000 milligrams a day for most women. And weight-bearing exercise, which is going to build stronger, healthy bones. We look at a Mediterranean diet. We try to support women in stopping smoking, reducing alcohol, and checking their blood pressure and cholesterol. So we look at your heart health and we look at your bone health as much as we can. So that's your kind of lifestyle intervention. Then after that, we talk about non-hormonal medications. So things like SSRIs and SNRIs, which would be traditionally known as more kind of used for things like depression and to treat anxiety. They're really interesting. Like, obviously depression and anxiety is such a common issue at this menopausal transition that it will treat those symptoms. But interestingly, these medications also seem to have a positive impact on hot flushes and night sweats, independent of their impact on mood, which kind of shows you there's a lot of crossover between estrogen and serotonin and what these hormones do and regulate in your brain. Like, hot flushes come from your thermostat, your hypothalamus at the back of your brain. And so we can, instead of using estrogen to treat those hot flushes, we can alter serotonin and have an effect that way. So SSRIs and SNRIs are really helpful. And we're fans of using them in women who maybe can't take HRT. Perhaps they've had breast cancer or something like that. And we have a few other medications that don't contain hormones that are very effective for hot flushes and night sweats. And then there's HRT. So HRT, will I keep going? HRT.
I'll just give you a second to breathe, maybe, because I know it's a lot of information. But I maybe just to pick up on something you said there, I think it's probably really important maybe for people to hear. So if they are prescribed an SSRI, it's there could be maybe a specific reason for that. And maybe it's as you say, maybe for people who can't take HRT, or maybe maybe it's someone who is aware that actually they're able to tell, or maybe with the support of a mental health professional, actually they, in addition to this kind of hormonal change, they can recognize maybe that this low mood is actually quite familiar and possibly even worse. So I guess it's kind of not like, oh, well, they prescribed X or Y, but there's possibly different reasons for different people as to why you might start off maybe in a slightly different place. And I think that's maybe helpful to know. Um,
And I think there's been backlash perhaps in social media and different things in the last few years, this kind of attitude of like, I went in and I was just given an antidepressant and kind of kicked out the door, although I'm sure, I hope to God that doesn't happen anymore.
yeah,
That's not right either. So
yeah,
like I talk about antidepressants, SSRIs and SNRIs with every patient who comes in, because
okay,
I think it's we have this kind of buffet of options and then we individualize it. And
yeah,
should antidepressants be given first line to everyone above HRT? Definitely not. HRT is more effective for most
yeah,
things, we know. Are they part of our toolkit, really safe and effective? They are. So they should be part of the discussion, and it
yeah,
will depend on the person in front of you and their specific issues, background, medical history, and all of that. That'll depend. That'll kind of guide you to where you end up. Yeah.
yeah,
In terms of HRT, so in brief, it's a combination for most women. It's a combination of estrogen, which is usually prescribed through your skin. So estrogen in its tablet form can slightly increase the risk of blood clotting. Estrogen through your skin, people have probably heard of the patches, the gels, the spray,
mm,
um, is lower risk from a blood clotting point of view. So the tablets can trigger some production of clotting factors from your liver, and that slightly increases your risk of blood clotting. Why would we go that route if we have an option that doesn't do that, which is why most people end up on the dermal stuff.
sure,
So that's your estrogen. If you still have your womb, the problem is that estrogen can cause thickening in the lining of the womb. And to protect that from happening and stop that from happening, we prescribe a second hormone called progestogen. And again, there's lots of different combinations here and different ways of doing it, but just the most common would be to take your progesterone by mouth. With a thing called micronized or body identical progesterone, or some people might use a Mirena coil, a
mm,
little T-shaped device inserted into the womb, which also releases progestin, because it's great at treating heavy bleeding, and it's birth control, it's contraception.
okay.
So that's called combination HRT.
And you had mentioned earlier the progesterone, it might have low level kind of anti-anxiety properties for some people, maybe.
Yeah, so there's progestogens, which is a bit like
Yeah,
saying car, and then there's
okay,
progesterone, which is like
okay,
saying Volvo. So
yeah,
so the progestogens in general don't have that effect,
sure.
unfortunately. So the progestogens you find in like birth control or the Mirena coil, for
Okay,
example,
sure.
won't have that
Okay,
anti-anxiety effect
yeah,
at all. Specifically, I'm actually conscious of the fact I'm actually sitting beside all my little dummies, so I might show you them if you want
okay,
to see them.
great. Yeah,
So
yeah, go for it.
progesterone, which
Yeah,
is a relatively modern, like it's only been around for probably 20 years or so, 10 or 20 years. Progesterone, which is our first line, because we think it's probably the most breast friendly. So it seems
okay.
to have the least impact on breast cancer.
Mm,
But specifically this type of progesterone, so they're little capsules.
yeah,
Um, so they're the ones that seem to have, so basically when your body breaks down progesterone, whether it's in this form or from your ovaries,
mm,
that little metabolite that comes off like a little byproduct,
yeah,
that's what has this anti-anxiety effect in your brain.
okay.
So you won't get that with the Mirena coil. I actually have that. That's the estrogen gel.
Okay, great.
That's the estrogen spray. I can show you them later if you want. And we have some
Yeah,
patches in there as well. But yeah, there's lots of different
yeah,
products. That's where it gets confusing.
yeah, yeah. And I guess there's a lot of questions coming in around testosterone. So I don't know if you want to say a little bit about that and where that might fit for some people, not
Okay.
everyone, perhaps.
Yeah. So your ovaries produce three hormones. They produce estrogen, they produce progesterone, they produce testosterone. Now you make all of these three hormones also from other parts of you, like your adrenal glands, adipose or fat tissue. Other parts of you make these hormones too. When you are having periods, like in your kind of normal reproductive life, the vast majority of your estrogen and progesterone, like almost all of it, comes from your ovaries. When you get
Mm,
to menopause and your periods stop, they're the two hormones that you lose. Testosterone is totally different. So really from your kind of late 20s, early 30s, your testosterone production from your ovary starts to decline. Doesn't matter when your final period actually happens, it just declines at a steady rate into your 50s. And then inexplicably in your kind of mid to late 70s, it starts to go up. No one knows
mm,
why, which is really interesting. Presumably some evolutionary benefit of some description. I don't know. Anyway, so it doesn't matter when your final period happens. Like your loss of testosterone is not linked to your loss of periods at all,
okay.
which I think is a bit of a misconception. So it's not really a menopausal hormone at all.
Mm,
Um, we have, so the issue with testosterone really is that we don't have a lot of data. So it's kind of a modern thing, this concept of like, I wonder, should we prescribe testosterone for women and would they benefit? So the current thinking is that some women will and some women don't at all.
Yeah.
A lot of women come in and ask about testosterone for things like cognition and mood and energy levels, or even like building muscle strength and that kind of thing. We have no evidence for that. That's the problem. And I don't know, is that because it doesn't have an effect on those things, or is it because we haven't studied it properly, which is very possible. Most of the research into testosterone has actually been done in Australia. Professor Susan Davis is the kind of leading voice on this. So she, along with some of the other menopause societies, produced, I think, what a consensus statement about 4 years ago, based on, here is all of the, like, what do we know? This is all the research we have. Where are we with testosterone? They came to the conclusion, and they have stuck by this now since then, that we only have evidence that it's good for low libido, for low spontaneous sexual desire. So the only real indication to put someone on testosterone is to manage low libido or low sexual desire. The problem is anecdotally. So you'll get women coming in saying, I have a friend who went on testosterone, her cognition improved. I'm struggling with my brain fog. Should I go on it? And I'm like, I don't know. That's the problem. So it comes in a little sachet of gel.
Okay.
There are, again, there's different brands, but this is the one that we would prescribe. And this sachet would last you about 10 days. And you apply a little pea-sized amount to your thigh once a day.
Okay. And I guess it would, if someone was kind of interested in that in terms of low libido, as you say, for its indicated use, is that something they would talk to the GP about? Or is it that a menopause specialist?
I think it depends on your GP, to be honest. You know, so I think if someone comes in talking about low libido, you have to take a little step back first and say, wait a second, so what is causing the low libido? It itself is really complicated. Like normalize it. So if I talk to 100 women a week, I talk to more than that, but anyway, if I talk to a few hundred women a week, 99.9% of them would say libido, like, I'd rather read my book and have a cup of tea. But I think normalizing it is really important. There is nothing wrong with you if your spontaneous sexual thoughts and spontaneous sexual desire have dropped off. That's actually normal with biological aging. It's completely normal. However, if it's really bothering you, which is also fine, we look at different things. So are you on a medication? Like, one of the downsides of the SSRIs and SNRIs sometimes is that they can have a negative impact on libido. The problem is, so does depression and anxiety. So you have to kind of manage that a little. And then we look at vaginal symptoms. If you have dryness, if sex is painful, even like we lose some clitoral response with the loss of estrogen in the vaginal tissue. So all of that can also contribute to low libido. That has to be fixed first.
I think it's a really interesting area, isn't it? Because I guess it's so holistic, and it's interesting that I'm just thinking about my own training in psychology. I don't think we ever really spoke about this, or really had much teaching on it. And I guess thinking about people who come in at different ages, not really kind of having a grasp of where they might be, in relation to some of this. But as you say, it's sort of because people might have, well, I heard this was really good for that, and kind of come in and say, this is sort of what I want for this. But actually there's probably a real benefit, isn't there, in terms of a fairly in-depth conversation about what's going on for the person, what the symptoms are, and crucially, as we're saying, how they're impacting you, and what are the ones that are
all
most
different.
troubling. As you said, the night flushes might be tricky for some people, but actually something else is a much bigger priority. As you said, maybe it's the brain fog at work. Maybe that's the area that really needs the attention. There's a question in there that it's kind of echoed throughout, and I'm just aware as people are asking questions. Thanks so much for all of the questions. There's a huge amount. I think we'd be here all day and probably still not get to all of them. So my apologies really if we don't get to your question. I really would encourage you to talk to the GP, and we'll do our best to get through them. There's a lot of similar themes, and as I said, kind of maybe one of the most similar themes is how to get the GP to maybe hear what someone is saying around these symptoms.
Are you putting that question? Do I have to answer that question?
No, as a GP, I think it's complex,
like anything, but GPs are people too, and we have our own personalities, and you're going to click with some people, with others. And I've worked with GPs who are so efficient, like they can diagnose it at the door, and they're just brilliant, and they're very clinical. And I've worked with other GPs who are much more suited to maybe the kind of longer and more in-depth conversations, and they're, and I think it's maybe about finding someone that clicks with you and what you want as a patient, and it's not going to be one size fits all. That's a really crap answer, isn't it, Susan? It's the best I have, I think, because there isn't really an answer to that.
Yeah, there isn't. But I guess maybe it's sort of normalizing it as well. If you're going to your GP and maybe not feeling that it's quite getting to it, you're wondering if it might be menopause, you're probably not alone in that. And I guess, as you said, Kiva, that we're moving towards more research and more kind of understanding in this area. And maybe that takes a bit of time as well. As you said, even those nice guidelines aren't fully kind of completed, and they're just for the UK as well. So it's not even, we're getting there maybe. But it's
But look, for
probably
someone who
worth.
has an interest in it, like a lot of the
Yeah.
practices now, when I worked in Canada, there was a real sort of push towards subspecializing. That's how I ended up in women's. I was delighted because
Yeah.
I wasn't suited to general practice, loved women's health, was much better at women's health, thankfully. So I sort of jumped at that opportunity, and we were all, like, a lot of the GPs that I worked with would have a specialist interest in something. That wasn't a done thing in Ireland, but it's becoming more common now that you'll find within a practice, there's someone who
Yeah.
she's the person you go to if she's an interest in women's health, or he's the person you go to, he's an interest in women's health. So, maybe try and suss out, is there someone who's actually interested in this particular area? That can be
Yeah.
helpful.
I think that would be good. And as you said, there's probably going to be more and more of that across kind of surgeries and different centers. Okay, just kind of having a look at the questions here. And we haven't sort of spoken about it. Maybe just as I'm looking through, I wonder, is it worth saying a little bit about, so for people maybe who struggle with some aspects of HRT. So maybe sometimes, I guess, the progesterone, as you said, kind of, there was a question in there about day or night, which might be helpful to think about, and maybe how it relates to fatigue.
Yeah, so that the body identical progesterone, some people call it body identical progesterone, uterogestin, micronized progesterone, is all the same thing. Because it is slightly sedative, we advise that you take it at nighttime, and you should take it on an empty stomach. So you take it with some water going to bed, and it'll help your sleep. For the majority of women, there's a small percentage who are very unlucky, like 10% maybe, who go the other direction and they feel absolutely god awful on this particular progesterone. That comes to light pretty quickly, though, within a week or two, and we address it. But for everybody else, the other 90%, it should improve your sleep, but take it at nighttime. If you take it in the morning, you're going to feel woozy if you're unlucky. So I wouldn't do that.
Okay.
The other progestins, obviously the coil, or that doesn't matter a jot. You can take them anytime. But in terms of kind of troubleshooting HRT, that's a huge area, obviously, and it's very individual. But there are certain issues that crop up for us repeatedly. One is, I'm on HRT and I'm not better. What do I do?
Okay. Yeah.
And the other is, I'm on HRT and I'm bleeding, which is often more a kind of doctor-led issue. We pay attention to it more. We're worried about it more than the patient is a lot of the time. So in terms of, I'm on HRT and I don't feel better, what do I do? So either your HRT is wrong, so you're on the wrong dose, or you're on the wrong route. And we're kind of learning more about potentially like issues with absorption, especially with these dermal products. So you put a patch on me, we might end up absorbing different amounts of estrogen due to like our skin type and our body shape and our genetics and our enzymatic concentration in our skin, like all these different factors. So you might end up absorbing differently to me. And some people get a better response from one product versus another, from the gel versus the patch versus the spray, etc. And then there's other women we end up putting on tablets because they just don't respond well to any of the dermal products, which is fine if you're low risk for having a clot. Then there's other women who get side effects from the progestin. So a lot of women who talk about having an issue with taking the pill in the past, my ears always prick up a little, because they're often women who are sensitive. If you have an issue with the pill, 99% of the time, it's the progestin in the pill. The pill is usually a combination of estrogen and progestin as well. So it's usually the progestin. Most women get on fabulously well with estrogen. The issue is the progestin. So if we think it's a side effect, as opposed to, I feel awful, I started HRT, I still feel awful. If it's, I've started HRT, all of these other issues have got better, but now my mood is really bad and it wasn't bad before, that might be the progestin. So that's often worth changing. See, this is so much nuance in it, and this is why the consultations are long, I think. A lot of women talk about breast tenderness on HRT as well, or headaches in the first few weeks. So that's really common. One, I like this isn't very as in it's not, I was going to say not very scientific. It is to some degree, but it's not really covered by a guideline. But we kind of over the years, I think the best approach is to start low and go slow. So a lot of the time, if we're heavy-handed with estrogen and we go in with big doses, we make women feel worse. So they get breast tenderness, they get bloating, they get headaches, they might even get nausea, they feel dreadful. And starting low and sort of gently titrating up is a much better approach. It might take longer for you to get rid of your symptoms, but you'll feel better overall. Yeah.
Okay. So there's definitely a value, I suppose, in, as I was saying at the beginning, maybe kind of keeping a note, maybe whether that's writing it down or an
Keeping a
app or
record.
something, and saying when does mood sort of change, kind of when are those symptoms kind of more pronounced, when are they not, so that you can sort of report back maybe to someone like yourself and say, well, this is what it's been like for the last 2 months. Where do we go from here? That's probably quite helpful. You're kind of noticing symptoms.
Really helpful, yeah.
I just saw a question come in there about the motorway driving. It sounds like it really resonated with the person and that kind of anxiety. And I think it really speaks to the huge impact, I think, on mental health and daily life, really, in a way. So as you were saying, maybe someone who's kind of maybe doesn't go on the M50. I know it can be a time when a lot of women kind of leave their jobs. Well, maybe not a lot, but that can be something that happens. And I suppose that's where the CBT part is really key. So someone had asked in the questions, what is CBT? So that's cognitive behavioral therapy. I won't go into that now because we're kind of a bit pushed for time, but there's loads of information on our website, aware.ie, where you can also do cognitive behavioral therapy kind of education programs. So they're all based on that model. I think it speaks a bit, doesn't it, Kiva, to that idea that it is quite holistic. So there's the biological piece, there's kind of getting the hormones right. There's maybe whether there's a role for SSRIs or not, is again going to be different for different people. But there's also a lot that you can do in terms of how you respond and cope and kind of bolster those kind of coping techniques. And I guess there's something about the self-compassion that I mentioned and not kind of getting caught in that, maybe that vortex of self-criticism or maybe hopelessness as well. I think a lot of people, and maybe a lot of stuff in the comments there, it can feel very, very difficult. There's something really normal in that, isn't it? So as you said, it's like a huge whirlwind of change. But it might be difficult, but doesn't say it's going to be hopeless, as you said, but it may be normalizing that it can be very challenging.
Yeah, absolutely it can. And there's a reason we see higher rates of depression and higher, other things that happen at the menopausal transition. So there's something to that. Like, you are not alone to struggle with this kind of, combination of different symptoms, whatever they happen to be. Although, as I say, lots of women are fine, just to, it's not awful for everyone, but they're the people, I suppose, that we are trying to reach, are the people who are struggling. And I think it's worth, when we talk to someone about HRT, like, HRT is the most effective treatment that we have, especially for physical symptoms like hot flushes in particular, but it won't fix everything, and it doesn't fix everything. And a lot of women get very frustrated that I'm on the HRT, but I'm still not feeling great, which can happen. And I think if you bring it back to, like, a lot of the reasons that you're not feeling great to begin with it's multifactorial, like you'd mentioned, that there's the psychological piece, it's confidence, it's the other stressors that you have in your life with parents or kids or job or whatever it might be, and there's biology. It's all of this mixed in a big melting pot. So there isn't one thing that will fix all of that.
Sure.
And I think it's really important to know that you can decide to go on HRT and still take an SSRI and go to CBT or attend or do CBT, or any mixture of this, and exercise and the lifestyle changes, and look at how you sleep and reduce your alcohol, like all the other things that we do. It's not one or the other. It should be a patchwork quilt of all of these options that addresses your particular symptoms. But I think, like, we're very conscious of not being like, go on some HRT, see you later, you're fixed, because that's not how it pans out for a lot of women. It's just part of a bigger picture.
It's interesting, isn't it? Because I suppose it's at a time of life where, as we were saying earlier, there's so many plates, but it's probably a absolute time for self-care and prioritizing.
It's really hard. It's actually, it's just really hard being, I think, I don't know, like my mother claims it wasn't as hard. And
Yeah.
she was at my stage of life, and I think it's really hard for a lot of
Yeah.
women because the expectation and pressure is your outward face is always everything
Yeah.
is fantastic.
Mm-hmm.
I don't know, sorry, we're kind of off track a little, and it's not really, I'm no expert in social media and all that stuff, obviously, but you'd wonder how much is due to this constant pretense, or like it never ceases to amaze me, women coming in talking about libido, for example, and
Mm-hmm.
almost sort of divulge, like confessing, I'm not interested in it anymore. I'm like, of course you're not. Like, you're getting home from work at whatever time, and then you're doing X, Y, and Z in the evening, and there's biology, and that's normal too. Like, it's so normal, but they think they're on their own. They genuinely think I'm unusual, and they're not at all. Yeah, I really, it's so hard.
Mm-hmm.
It is. And I think a huge part of what we do is actually just support.
Yeah. Yeah. Yeah.
I think that's therapeutic. I think allowing someone describe how they feel and get the reassurance that they're not going mad and they're not falling to pieces, and that what is happening to them is happening to them, and they're
Mm-hmm.
actually most of the time doing really well
Yeah.
and just need some support and maybe address their biology and all that kind of thing. That's therapeutic in itself.
Yeah. No, absolutely. To be heard, I think,
Yeah.
and
Yeah.
have but crucially have a plan of what's going to be
Yeah.
the next step and what's going to help. And I suppose I wonder, maybe there's questions kind of coming in about where someone might kind of find CBT. As you say, that's a kind of wider question in terms of looking at specific therapists, or maybe again at our website. But as you say, it is a patchwork kind of quilt of the different interventions. So it is very hard, but also there is a lot of avenues for help and support. So I don't know, I guess we kind of mentioned the GP a fair bit, but would you recommend any other kind of places where people can find out more specific information?
Yeah, I mean, specific to my area, if you like to, in terms of
Yeah.
menopause and perimenopause, we direct a lot of people to the Women's Health
Okay.
Concern.org.uk, which is a website that has really good patient leaflets, really good information about non-hormonal options, really good information about HRT. It actually has a really good leaflet going through the history of HRT, the
Great.
Women's Health Initiative back in the 90s, breast cancer risk. They have a great graphic of
Yeah.
like looking, an illustrative way of looking at breast cancer risk with HRT, which is really helpful, I think. Um, they're actually run by the British Menopause Society. They're the patient arm of the British Menopause Society. The other one is the International Menopause Society, which again has a really good patient arm for kind of non-medics. And hopefully at some point down the line, we will have the Menopause Society of Ireland patient
Hmm.
arm, which we are working on. So I'm co-chairperson at the moment with
Great.
Claire Cromwell, who's a brilliant GP specialist down in Cork. And we have a fabulous board. We're now sort of established about almost a year, just shy of a year. But it's on the agenda for the next, it's in our kind of 5-year plan to set up a patient information area that would be specific to Ireland, that would have Irish resources, that would link to Irish counselling, Irish physio, etc. So watch the space. Hopefully down the line, we have a website if people want to check it out. It's menopausesocietyIreland.ie.
Okay, brilliant. So there's lots of different kind of supports, yeah, and there's something in there about support groups, and I suppose it's finding about the right fit for what's going to be helpful. For some people, it's kind of information online. For other people, it might be meeting other people. So again, it's sort of knowing yourself, isn't it, and getting linked in with the kind of different supports that are out there.
And if you're complex, obviously, there's the
Yeah,
complex clinics through your GP, then you can get a referral to wherever
yeah.
you're
So
appropriate to go to. Yeah.
yeah, and as you said, there's kind of, which is great to hear, that's not just Dublin based. So there's 6 around the country. So that's a conversation with your GP, and to see kind of whether you can access that.
The Coombe,
Um,
the Coombes, the Coombe is the one I left out earlier. There's 3 in
oh,
Dublin. The
right.
Coombe. There you
Okay.
go.
Nice, nice symmetry to to come to an end. Yeah.
I God, I remember that.
Um,
I'd be losing a few friends over that if I forgot. How did I leave out the Coombe? The Coombe, yeah.
maybe because it's too near, but yeah, I'm sort of reluctant to let you go, Keith. I know that you've got a very busy day as well, but I really just to kind of reiterate our huge gratitude. I can see it's a really interesting topic. It really resonates with a lot of people, huge amount of interest. So thank you so much for your time and your expertise, and I guess may also kind of very kind of hopeful, optimistic approach as well. It feels like it's a much better place maybe than it was before. So thank you so much for
I hope
contributing
so. And but
today.
thank you to yourself and to Siobhan and everybody at Aware for and everyone who came. Like, we're not be awful if we were talking into the ether and there was nobody listening to us. So, you know, the whole point is that there's people there. So thank you to everyone who joined today and who listened. Yeah.
Yeah, absolutely. Thank you, everyone, for joining. And again, my sincere apologies if we didn't get to your question. Do have a look at the resources that Caoimhe has mentioned, and maybe speaking to your GP as well. And who knows, sure, we might do another one. We won't wait 3 years. Maybe I think the interest is so great.
Yeah.
Yeah, so we'll maybe come back to it. But thank you, Caoimhe, again. Thanks to everyone for joining.
Thanks so much. Thank you.
And moving on to our webinar for next month then. So it'll be on the second Wednesday in December. And that is going to be supporting someone with a mental illness. So please do tune into that if you can. So thanks again, everyone, for sharing today, for your questions, and hope to see you next month. Thanks again, Caoimhe.